discussed yesterday, we went through what we call the introduction to assisted reproductive technologies, in brackets, what we call ART. And like we had discussed in the previous lecture, apart from the one of yesterday, we looked at some of the different ART methods that have been that have been innovated as a way of trying to solve the issue of infertility. Having discussed infertility earlier on, and yesterday we were able to cover the introduction to ART, and we said this is a set of fertility procedures that help people conceive by artificial fertilization. And we looked at some of the methods, and once again today, yes, and once again today, I want us to look again deeper into some of the methods, but also I want us to understand how some of these art methods work. And we shall go through them. Some we went through, like this IVF, we went through them, and we said these majority of these particular methods are determined by age, but also some of the demographic factors. And that is why you can be able to see here that for this example we gave for the IVF, that for instance, the 2018 success rates of IVF treatments for one on-site retrieval from people using their own eggs were 52 for people aged 35 or younger. And you can be able to see 52% for people below the age of 35, but also it keeps reducing drastically to 38.1% for people aged 35 to about 37. And then it further reduces for the age group 28 to 20, and it is more or less for those who are aged over 40. So whereas we may realize that these art methods are efficient, probably some vary about 78% efficient, you also realize that the variations are according to age, or that age is able to affect these particular kind of art methods. So we just also looked through the considerations and the costs, that they are quite expensive, but also that they increase the chance of fertilization because they are somehow effective. And the controversy is that it is not, so sometimes it comes with a lot of side effects that might include cases of preterm birth and so forth. So we looked at some of the potential complications, where we looked at multiple pregnancies. We looked at the side effects of the drugs as a potential complication, because then there are some. Then kindly mute. Then can you mute? So we looked at these side effects, and we went through and also realized some of the potential complications of pregnancy. Then kindly mute your microphone. Or Samuel, you can mute, eh? That's like him, you can mute him, eh?
Mr. Link, please, you're disorganizing the lectures. Mute.
I think he's away from his gadget. Please, Deng. Then
Yes.
can you mute? Kindly mute, eh? Kindly mute. Kindly mute your microphone, eh?
Okay. Let me mute it here.
So some of the potential complications we also looked at is that as a result of using some of these art methods or art technologies, there are chances of ectopic pregnancies. And when we are talking about an ectopic pregnancy, we're looking at a situation where the embryo is settling outside the womb. And we ask that you further go ahead and look at some of the symptoms and signs or risks that are associated with the ectopic pregnancy in the context of art. Then another method we looked at, remember earlier on we looked at the IVF, then we looked at what we call the intrafallopian transfer. And we said these use what we call the laparoscopic surgery to deliver gametes directly into the fallopian tube. And there are two types of this particular art method. There's what we call the zygote intrafallopian transfer and what we call intrafallopian interfallopian transfer. Just like you're able to see here, we were able to look at the method through which this particular transfer occurs. And we said the types as here, there's gamete and zygote and the pronocular stage tubal transfer. And then we looked at how the fallopian or the intrafallopian transfer occurs, but we're going to be able to look at it again in here. So for those who did not have a glimpse of what we covered yesterday, there is a slide in here that I have just put so that we can be able to further understand the key types of intrafallopian transfers. And I want to start with what we call the zygote intrafallopian transfer. The zygote intrafallopian transfer, which we abbreviate as ZIFT, is an assisted reproductive technology first used in the 1986 to help those who are infertile to conceive a child. Now, the ZIFT is a hybrid technology derived from a combination of in vitro fertilization. So you should be able to understand in vitro fertilization because it is also used in this particular technique. So ZIFT is derived from the combination of IVF and the combination of GIFT, or what we call the gamete intrafallopian transfer procedures. However, despite the relatively high success rates close to that of IVF, it is not as common as it is parent procedures due to its costs and more invasive techniques. So whereas this zygote intrafallopian transfer has very high success rates, earlier on we discussed that it is actually the IVF or the in vitro fertilization method that has higher success rates compared to these other methods. But we're again also saying that zygote intrafallopian transfer is closer to IVF. However, because it is closer, it is not yet one of the it is not one of the common types of procedures that are used. And we're saying it is possibly because of its high cost, but also it requires quite very many, or what we call the invasive techniques. So some patients prefer ZIFT, however, considering it more natural because the fertilized oocyte, the zygote is placed in the woman's body for implantation much sooner than with IVF. So, in other words, we're saying that some people or most women would prefer that they use this ZIFT method. Probably one, because just the difference is that the fertilized embryo or what we call the embryo, is placed into the woman's body sooner than that one of IVF. Because for the IVF, you have to wait for a particular period before you can be able to insert it. So to be a suitable candidate for ZIFT, a woman must have at least one healthy fallopian tube where the physician can implant the zygote. So the entire ZIFT process takes approximately 4 weeks, and it includes the period when the patient must first undergo hormone treatment or called superovulation. And we'll also look at this superovulation in the intro vitro fertilization. And we said with superovulation, the physician administers fertility medications such as clomide. And this clomide is to stimulate the ovaries so that they are able to produce several mature eggs, or what we call the ova. And clomide will increase the amount of follicle stimulating hormones and luteinizing hormones in the female. Now, these two hormones that are required for oocyte maturation, when they are released in the body, then there are chances that the oocyte will mature. However, if clomid is not enough to stimulate oocyte maturation, the physician can also inject the patient with additional follicle stimulating hormone and the luteinizing hormone intravenously to supplement the oral clomide medication for a more aggressive hormone therapy. So sometimes after you've been able to inject this client, there are chances that they may not be able to react, or the maturation process may not be able to stimulate ready maturity. And therefore, they are advising here that after someone has swallowed this oral pill, the physician can also inject an additional follicle stimulating hormone, or this particular oral clomide, so that it has more aggression in trying to increase the maturation process. So once the hormone treatment helps produce several mature ova, the physician extracts the ova through a non-invasive procedure called transvaginal oocyte retrieval. This is the same technique that is used with the IVF and gift, where the egg, or non-invasive means that it is not a surgical kind of procedure. So you're able to. It is not very. It does not require a lot of complication. So the physician can be able to extract that particular ova. So the same technique that is used in the IVF is used here. And for this transvaginal oocyte retrieval, a thin needle guided by a sonogram is inserted through the vaginal wall and enters the ovaries to extract several mature ovum. So this particular syringe or needle, that is guided by a sonogram acts like a pipette, where you're able to extract these mature ova. Then shortly before implantation, the physician obtains the sperm from the male either by masturbation or by using a condom or a collection condom, or with the surgical methods if there is an obstruction preventing the normal ejaculation of a sperm. So the main aim here is that immediately after this mature ovum or ova uh, have been extracted from the woman, and then immediately the sperm is collected, and we're saying this can be collected either after masturbation or by using a collection condom. Or if this person may not be able to do any of those, they have to use a surgical procedure so that these sperms can be removed. So once the sperm and the oocytes are prepared, the physician allows the sperm to fertilize the oocyte in a petri dish, either naturally or manually with a procedure called intracytoplasmic sperm injection, which is also another time or which is also another method that we shall further look at later. So this particular mixture is put in a petri dish so that the fertilization can take place. So if there is a male fertility problem, such as low sperm count or a high concentration of mishapen sperm or low sperm motility, ICS is a good procedure to use in conjunction with this shift. So you may realize that these are actually procedures or methods that may be used concurrently. So here we are trying to show majorly what particular method can be used for what particular condition a client may be suffering. That's why we're saying that if the problem is a male fertility, that the person may not be able to have a strong sperm count or the concentration of what we call mishapen or misshapen or misshaped sperm or the movement of sperm is very low, then it is important that they use this intracytoplasmic sperm injection. So the intracytoplasmic sperm injection is a good procedure to use vis-a-vis this ZIFT. With the ICSI, the sperm is injected directly into the egg in the petri dish. So immediately, these ova are removed. Using a needle, the sperm is injected straight to the egg, what we call that intracytoplasmic sperm injection. So studies are conflicted on whether ICS will increase the chances of birth defects in newborns, but any increased chance is too low to determine accurately. So many people have had discussions on whether it is possible for this ICSI method to cause a lot of birth defects or a lot of disabilities. But again, we are saying here that it may not be easy to determine accurately whether it can cause a lot of those particular problems. So let's look at that now after fertilization in vitro. So meaning after the process of fertilization in that petri dish, the physician monitors the fertilized oocyte or oocytes. Now here we're talking about an oocyte or we're talking about an embryo, meaning that fertilization has taken place because the sperm has been injected into the ovum. So this monitoring is appropriately for 24 hours until cell division begins. So with this zygote intrafallopian transfer, the physician then implants the zygote into the fallopian tube. So this differs from the IVF, where the physician waits until the fertilized egg has divided into 8 cells before implanting it into the uterus. So you should be able to clearly understand the difference in here. When we are discussing about a ZIFT process, a ZIFT process occurs immediately after the 24 hours. When cell division begins like this, this particular embryo or oocyte is injected into the fallopian tube. However, in what we call in vitro fertilization, the physician has to wait for until the eggs are divided into 8 cells before it can be implanted into the uterus. whereas here is on a short term, and here it is inserted or it is implanted into the fallopian tube, whereas in IVF it is implanted into the uterus. So the location where the physician implants the developing embryo depends on the stage of the embryo's development, and thus models the path that developing embryo would follow after natural conception. So it is after the physician to understand how far or what is the type of growth that this embryo has taken, or what is the period that this embryo has taken, so that they're able to say if it is this particular period of time and these are the processes, cell division has started, the 8 cells have appeared, then it is upon the physician to be able to clearly determine that this will be the particular path through which the embryo will flow following conception, and will be able to implant that particular embryo at that time. So that is during the IVF. So during the ZIFT, the physician places 1 to 4 zygotes in the fallopian tube through a surgical procedure or a surgical technique called laparoscopy, and an invasive procedure utilizing a small abdominal incision, unlike IVF, where the physician places 8 cell embryos in the uterus by entering through the cervix. So, what happens here is that an abdominal incision or cutting is done. So, after the procedure have been done using a procedure or a technique called laparoscopy, a very small incision is done so that these particular zygotes are inserted into the fallopian tube. And when they are inserted there, then they will be able to stimulate production of those particular hormones, where then luteinizing hormones, where then fertilization and conception can start to take place, and the development of an embryo starts to take place. However, you can be able to see that using the IVF, the embryo is entered directly through the cervix. So the IVF, unlike the ZIFT, does not necessarily have a surgical procedure. So the zygote then travels down the fallopian tube and hopes that it will implant on the uterine wall. In a healthy young woman, there is approximately a 32 to 36% chance that the fertilized egg will implant in the uterine wall and result in pregnancy. The number of zygotes the physician places in the fallopian tube will depend on the patient's age as well as her preference. For the greater the woman's age, the more difficult it becomes for pregnancy to occur. Thus, the physician may insert more zygotes to increase the chances of successful implantation, resulting live birth. So from that statement, you should be able to understand that virtually these particular methods, as I said earlier, are determined by age. So the chances were saying that this egg, because it has been fertilized, when it is placed in the fallopian tube, it is meant to travel through the fallopian tube and it is meant to settle at the uterine wall, so that then the development into a fetus can start. However, you can be able to realize that for those women who are a little older, or for clients who are aging or who are closing into their menopause, the physician would have to be able to implant more zygote, because then the chances that their particular zygotes may flow down through the fallopian tube to the uterine wall are limited for them in that case. So the second type we want to look at is what we call the gamete intrafallopian tube transfer. And the gamete intrafallopian tube transfer is an assisted reproductive procedure which involves removing a woman's egg, mixing them with the sperm, and immediately placing them into the fallopian tube. One of the main differences between this procedure and in vitro fertilization and zygote intrafallopian transfer is that with the gift or with the gamete intrafallopian tube transfer, the fertilization process takes place inside the fallopian tube rather than in a laboratory. However, healthy tubes are necessary for gift to work. So that I think that difference is clear. Whereas the in vitro fertilization and the zygote intrafallopian transfer are done in the laboratory and then inserted into the uterus and into the fallopian tube respectively, the gift transfer inside the fallopian tube. So gamete intrafallopian tube transfer uh, has procedures which I would like to discuss as below. Just a minute. So, if you're looking at the procedures for gamete intrafallopian tube transfer, one, we're saying that the patient must have an X-ray to determine the presence of at least one healthy fallopian tube. And we said that even for ZIFT, there must be one fallopian tube that is healthy. Then the doctor will also use a laparoscope to ensure that there is not any scar tissue on the outside of the fallopian tube, because then that is what determines whether the patient is eligible for this particular kind of transfer. Second is that using a laparoscope, eggs are then retrieved from the ovaries. Remember earlier on, for us to ensure that the eggs are mature or the ova is mature, we use fertility drugs that keep on stimulating or keep on making sure that the body releases the follicle stimulating hormones. So the male, after the ovaries are retrieved, the male provides a sperm sample the same day that the eggs are retrieved. And then the eggs are then mixed with the sperm in a catheter. The egg and the sperm mixture is inserted into the fallopian tube with a catheter. Then the woman is then provided with medication to build up the uterine lining to support the implantation of the fertilized egg. So you can be able to see that the only support that occurs here is through the catheter that that helps this particular mixture to be able to flow into the woman's fallopian tube. And when this woman is given treatment, the uterine starts to form a lining. And when the uterus starts to form a lining, then through the fallopian tube, the fertilized egg will travel down into the uterine wall. So what are some of the advantages and disadvantages of what we call the gamete intrafallopian tube? One is that the good news is that the gift does not require you to be hospitalized. After the procedure, patients typically stay in recovery for about 8 hours and then can move back to their particular home states. But also doctors cannot visibly confirm fertilization or determine embryo quality with the gift. So that is one of the disadvantages it has. But also gift cannot be used in patients who have damaged or blocked fallopian tubes. So those are the two particular disadvantages of using this gamete intrafallopian tube. But also some of them apply to the ZIFT transfer. So we looked at the frozen embryo transfer yesterday, and maybe just to take us through, it involves thawing previously frozen IVF embryos and implanting them into the uterus. So for it, the procedure is often used when the gestational parent has frozen embryos from a previous conventional IVF cycle. So after an IVF have been conducted, that particular uh, embryo that grew from the IVF is most times frozen in a fridge, or is kept in a position, or in an incubator where the right conditions are provided. So what happens is that this frozen embryo can actually be transferred to the uterus of an individual, and then fertilization will take place. And its procedure normally lasts for about 3 weeks, because during the first 2 weeks the gestational parent's uterine lining is prepared for implantation, and this is through tablets, where an individual is able to swallow tabs, and then can be able to can be able to can be able to be transferred into that frozen embryo, because then the uterine lining has to first be prepared. So what are some of the risks that are associated with intracytoplasmic sperm injection? First of all, this ICSI is an acronym for intracytoplasmic sperm injection, like we said. But in simple terms, this complicated word you're seeing here as intracytoplasmic sperm injection it's just a fancy way, or a nice way of saying inject sperm into an egg. So that is just the rough statement when we're talking about ICS. And we know that it is very effective in fertilizing eggs in the IVF lab after they have been aspirated from the female. Its main use is for significant male infertility cases. Uh, so ICSI involves the use of specialized manipulation tools and equipment, and inverted microscopes that enable embryologists to select and pick up individual sperm in a specially designed ICSI needle. So the needle is carefully advanced through the outer shell of the egg and the egg membrane, and the sperm is injected into the inner part, what we call the cytoplasm of the egg. So that is basically what that intracytoplasmic sperm injection is. But it usually results in normal fertilization in about 75 to 85% of eggs injected with the sperm. So it possibly has a very high chance of fertilization. But however, first the woman must be stimulated with medications, as the case for those other uh, methods that we talked about. And ICSI is an advanced, this is just a repetition. I think it's trying to further describe what ICSI is. And but the first human pregnancy was generated in 1991 by Gian Palermo. So let's look at some of the ICSI procedures. We were able to cover these ICSI procedures, but today we covered them yesterday a little bit, but today there are some more simpler statements in there that can help you understand it better. Step one is the egg retrieval. As in IVF, the woman's eggs are retrieved via a minor surgical procedure. Then the mature egg is held with a specialized holding pipette. So that laparoscope helps uh, to to open clearly so that using a pipette, like I said earlier, these eggs can be retrieved, and that is stage one. Now, in step two, the sperm is then collected, often through ejaculation or sperm aspiration. A very delicate, sharp, and hollow needle is used to immobilize and pick up a single sperm. So, after sperms have been collected, you have to have in a laboratory the microscope and be able to pick a single sperm, because we very well know that it is most times one sperm that can be able to fertilize an egg. The third step is a micro injection. So, having picked this particular single sperm on a needle, a single sperm is carefully injected into the egg's cytoplasm, and this needle is then carefully inserted through the zona, or what we call the shell of the egg, and into the center of the cytoplasm. So here you will always have to make it to the cytoplasm itself, and the sperm is injected in the cytoplasm, and then the needle is removed. Then the fourth step is that culture and transfer occurs, where the fertilized eggs or the embryo are cultured and monitored for a few days before being transferred to the woman's uterus. So here the eggs are checked the next morning for evidence of the normal fertilization. So the next morning you should be able to either see a cell division process occurring, and then you can be able to do the transfer. So some of the indications or the need for okay, indication would mean that why would you do an ICS? One would be if the male factor is severe. For example, the person has a low sperm count, the movement of sperm is very poor, and then the shape or the morphology of the sperm is poor. But also, if IVF has been failing due to fertilization issues, but also for frozen sperm samples with limited motility, there is a possibility or there is need or an indicator for using ICSI. So the success rates are very high, and they often exceed 70%. And the success depends on various factors, and these include, like we said, age, egg quality, and the clinic's expertise, how knowledgeable the person is. But also, ICS does not guarantee a healthy pregnancy. We should be able to know that. And the potential risks and ethical considerations need to be discussed with the patient. So before a patient is taken for this kind of procedure, these things should be done. So now we have been discussing a little of in vitro fertilization, and we realize that this in vitro fertilization actually cuts across all these other methods that occur. Therefore, we want to look at in vitro in depth, but mainly we want to focus on the 5 steps that are involved in vitro. We might have looked at it earlier on, but this particular slide here gives us further an explanation of how we can be able to look at in vitro and what steps we should be able to do. And one is stimulation. So a woman normally produces one egg during each menstrual cycle. But however, IVF requires multiple eggs. Therefore, using multiple eggs increases the chances of developing a viable embryo. So you will receive fertility drugs to increase the number of eggs your body produces during this time. Your doctor will perform regular blood tests and ultrasounds to monitor the production of eggs and to let your doctor know when to retrieve them. So, like we said, there are different tablets or medication that would be given so that this stimulation process of producing more eggs can occur. Then after that, after the doctor realizes that these ova are mature, then the egg retrieval is done. And egg retrieval is known as a follicular aspiration, and it is a surgical procedure that is performed with anesthesia. So your doctor will use an ultrasound wand to guide a needle through your vagina into your ovary and into an egg containing follicle. and the needle will suction eggs and fluid out of each follicle. So what happens is that using what we call the laparoscopy, or what people are calling here as an ultrasound one, where the physician can be able to look into the woman's reproductive system. They will slightly put in that particular needle, and they can be able to extract or retrieve those eggs. Then, and the third step is what we are calling insemination in there. And here we're looking at the male partner. We now need to give a semen sample, and the technician will mix the sperm with the egg in a petri dish. If that doesn't produce embryos, your doctors may decide to use ICSI, what we discussed about. So sometimes a mixture is done in a petri dish, mostly in this IVF. But if the embryo is not produced, we are saying that the ICSI may be used. And then second last is the embryo culture. And here, your doctor will monitor the fertilized eggs to ensure that they are dividing and developing. So the embryos may undergo testing for genetic conditions at this time. And we said that you will be able to understand this if the cell division occurs. Then lastly is what we call the transfer. And when the embryos are big enough, they can be implanted. This normally occurs 3 to 5 days after fertilization. And implantation involves inserting a thin tube called a catheter inserted into your vagina, past your cervix, and into your uterus. So your doctor then releases the embryo into your uterus, and then pregnancy occurs when the embryo implants itself in the uterine wall. And we say this one can take about 6 to 10 years. I mean 10 days, sorry. And a blood test will determine if you're pregnant. So that is about the art techniques that we're talking about. So we're left with about 10 minutes, so we can still be able to handle what I want us to handle in these 10 minutes. So we want to look at what we call surrogacy and gestational carriers. Some people may call it surrogacy or something like that, but I would call it surrogacy and gestational carriers. So a gestational carrier is a woman who carries a pregnancy for another person or couple. The gestational carrier is not genetically related to the child she is carrying. The eggs and the sperm are provided by the intended parents or donors, and then the embryo is transferred to the gestational carrier's uterus via an in vitro fertilization. So what happens is that when this IVF is done, instead of transferring this particular collection into another woman's uterus, it is into the donor's uterus. In that case, this transfer is done into another woman, but because she's not a genetical holder of the child she's carrying. She's just carrying children for other people, because then these children have this mixture or this embryo has undergone an IVF procedure. Whereas a surrogate mother is a woman who becomes pregnant using her own eggs and carries a pregnancy for another person or couple. So in this case, the surrogate mother is genetically related to the child she is carrying. This type of surrogacy arrangement is called traditional surrogacy. So surrogacy and gestational carriers are options for individuals or couples who cannot carry a pregnancy, but they wish to have a biological child. So in surrogacy, a woman carries and delivers a child for the intended parents using her egg or a donor egg. In gestational surrogacy, the surrogate carries a child conceived using the intended mother's egg or a donor egg, removing any genetic connections to the surrogate. So in surrogacy, you will be able to see that possibly it is the man who is donating a sperm so that this can the woman can be able to carry for and deliver for them a child. But for gestational surrogacy, the carrier or the carrier of the eggs does not have a does not have a genetic connection. Then we want to look at the surrogacy process, and the surrogacy process is that one, there is matching. The intended parent choose a surrogate, often with the help of a surrogacy agency. And this is just a process where people are able to talk to people they feel are able to offer them those particular uh, support that they want. They need an agent who can talk to that particular surrogate who could help them be able to conceive uh, a child. However, there is also a step where there is a legal agreement, and the legal contract outlines the rights and the responsibilities of the two parties. And then the IVF process takes place where the eggs from the intended mother or a donor are fertilized and implanted into the surrogate's uterus. And definitely pregnancy and birth. So the surrogate carries the pregnancy to term and then gives birth. And then we look at a process where there is parental rights. So the legal procedure ensures that the child's legal and the biological parentage is there. So some of these rights may vary country to country, but this is simply what happens. After getting a surrogate, you should be able to have a legal agreement. Then there has to be the transfer or the implantation of this fertilized embryo, and then pregnancy and birth, and later the parental rights have to be clear. So that is for a surrogate uh, carrier. So then if you're looking at the gestational carrier, we want to look at what some of the benefits are. And we're saying that it allows individuals or couples to have a biological child when pregnancy is not possible, but also it reduces the pregnancy-related risks for those unable to carry a pregnancy. But also it offers a solution for same-sex couples to have a biological child. So this is mainly in the modern world. Where they may get a sperm that is donated from someone, and then one person can be able uh, to to conceive a child and be able to raise, and they are able to call it their biological son, because this same sex may not apply in the context of us who are of African origin. They may apply mostly in the developed world, but also those of white origin. So, what are some of the ethical and legal considerations? Because we've earlier said that for you to be able to carry out these two methods, there is an ethical but also a legal consideration that has to be made. And we are saying that one is that surrogacy and gestational carriers involve complex ethical and legal considerations. And this includes that the surrogates have an informed consent. So they should be able to be clearly explained to what this particular process of surrogacy is, and then they should be able to make an informed consent, having been informed. But also there is need that these parental rights and responsibilities are clearly stated, and therefore so that it does not cause uproar in the future. But also you have to address potential disputes so that you can avoid So who will be with what? How will the child grow up? All these custody issues have to be by you immediately. Then we look at the compliance with local and international surrogacy laws. So you should be able to have ideas of how surrogacy laws are in your country or internationally, and you should be able to comply with them. So those are the ethical considerations that have to be or have apply. Let us look at some of what we call impact. Here they might be theories, but they so we want to look at the assisted reproductive technology, and we want to look at some of the theories. But we're not necessarily looking at what we call traditional theories. We're just looking at some of the aspects that have evolved as a result of the introduction of this art. And we're saying these techniques have given rise to several important theories and considerations regarding their impact on child development and family functioning. So we may not be able to look at especially theories, but we're looking at some of the considerations that have grown or some of the issues that have come up as a result of these art uh, methods that have come. So one, we want to look at art regulations. These are issues that have accrued from the. Are we okay? Are we good to go?
Yes.
That sound is coming from where? From me? From. Okay, maybe I can just continue. Considerations that have come as a result of this art include one, the art regulations. So as a result of the development of these technologies, there is need or there was need to regulate their usage, but also the way they operate. So art is subject to regulations in many countries. However, it is typically restricted or stable or legally married couples in South America and Europe. Asia often mandates marriage due to religious influences. Regulations globally tend to exclude homosexual couples or lesbians from accessing art. These regulations underscore the importance of evaluating art outcomes for the welfare of children. So some of the countries regulate these art procedures according to their own basis. For example, we are saying in Asia, it might be regulated according to the religious influences. And you may realize similarly, this may be there in Central Europe, maybe in Eastern Europe, for the cases of Italy, possibly because of their religious dominance in the Catholic, they may not be able to allow their followers to use such kind of technology. But also this may apply to the Muslims in Asia, possibly because this also uh, is away from their religious beliefs. Then we are looking at the family structure in art. This is one of the considerations or one of the theory that have come up as a result of art. And we're saying traditional family structures, particularly those comprising of two heterosexual married parents genetically related to their children, are the most accepted for practicing art. These This preference stems from the belief that such families offer the best environment for child rearing. Even as a societal change, uh, even as societal changes lead to variations in family structures resulting from art. So we're basically saying here that for families that have heterosexual marriages, but also who are genetically related to their children, it is ideal that they can practice art. Or when someone intends to do this art, they should at least be heterosexually married, because then if people are homosexuals, then one person may not have the particular gene, because then there's no way a male sperm can fertilize a male sperm as well. So therefore, it only can favor what we call heterosexual marriages. And for the sake of the family structure, it is ideal that these can be genetically related to their children. So the changing dynamics in art families today is that the dynamics of families created through art are evolving. So while the traditional model persists, there is a growing number of families with single parents, lesbian couples, or variations in genetic relationships between parents and offsprings. These changes raise important questions about the psychological consequences for children in such families. However, this I think this is very predominant in modern culture, or in well developed or developed countries, because then uh, we're looking at a situation where someone decides not to get married, or someone wants to be a lesbian, and therefore goes for an IVF, therefore goes to the laboratory where she can be able to undergo an over extraction, and then she gets another sperm that can fertilize her ova, and then this is implanted back into her uterine walling, and then at the end you will realize that they are single parents, and at the same time they are carrying children that are of their own, and therefore we're saying that this could be a key factor in the psychological consequences of the children, because if they are growing under single parenthood, then the chances that they will grow with such similar bad societal values is very high. So the acceptance of art families varies widely in societies. Families formed through art may encounter prejudice from relatives, friends, and their communities, and the negative attitude persists in many cases, viewing art procedures like in vitro fertilization as unnatural or immoral. So the societies we live in, the chances that they could be able to relate with these art methods, or people or individuals in certain families that are undergoing art, is relatively low. And this is because in many of our African settings, we believe that these are immoral procedures, and these are not unnatural behaviors, not only in our African setting, but also in our religious beliefs. We do not believe that these may occur, and therefore the acceptance of such families may become very hard. And it's often true that these families may face a lot of segregation, but also stigma from many more societal members. So some of the positive and negative outcomes is that art families exhibit a range of outcomes. The positive outcomes may include sensitive responding, emotional availability, and the combination of warmth and control, meaning that people or families that have practiced art may become emotionally available to their children, and they may be a little sensitive responding to some of the negative chants from the society. But the negative aspect is that there can be parental psychiatric disorders and marital conflicts that influence child development. So most times, child development may become an issue because then this child, if it is surrogacy, uh, it is a woman, another woman who carried it for you. So it may have a lot of psychiatric disorder issues, that is mental issues, but also marital conflicts will come along and this will affect child development. So the child may become single parented and this will be very hard. So there are some of the evolving perspectives of art, and we want to say that societies grapple with the ideal family structure resulting from art. And some studies suggest that mothers in art families exhibit greater warmth and emotional involvement with their children, while fathers may be more involved in parenting than in naturally conceived families. These changing dynamics require ongoing research. So, studies have shown that when a woman undergoes or gets their child using art, they're emotionally attached to them. Why? Because they would feel this is their only being, and they would not have gotten there if it was not for art. But we're also seeing that the fathers will become more involved in parenting these children, whereas in the societies today we've been seeing that parents or fathers are actually running sometimes away from the responsibility of fathering these children. So we want to give some of these recommendations for these art policies, and we're saying that they should not discriminate against any fertile individual based on their marital status when accessing art. Uh, Here it is supposed to be any infertile. So policies should promote inclusivity while ensuring the welfare of the offspring. And unmarried couples should provide written consent for art procedures, and regulatory bodies must establish laws prioritizing well-being of children born through art. So here we're looking at the psychological aspects and child development, and we're looking at welfare at a communal level of families that are practicing art. So these are some of the recommendations we're giving so that these can help. So some of the legislations that have occurred and that are linked to art. Art is subject to regulations in many countries. However, these regulations often address genetic material donations and the involvement of third parties in reproduction. So art practices are influenced by cultural, religious, and legal factors, leading to diverse regulations. However, regulations differ from country to country. So up to that far is where I wanted us to end for today, so that tomorrow we can be able to look at this particular aspect of what we call genetic material donation, which is the next topic that we want to discuss in this introduction to assisted reproductive technologies. So up to that far, do we have any questions, any comments as we conclude for today? Tomorrow, I'm thinking we can have our engagement at 8 Ugandan time, so that will be 7 SST time.